Good morning, everyone. We are now going to start the session Cancer. My name is Margaret Thorsteinsdóttir, and I'm professor at the University of Iceland, and chairing with me is...
Hello, my name is Lime. I'm from University of Tübingen in Germany.
So I'm very proud to announce our session keynote speaker, Jacopo Troisi from Theo Aurea, a spin-off company of the University of Salerno, Italy. And he will talk about the metabolomic way for the screening of endometrial cancer. So welcome, Jacopo.
Good morning, everyone. Thanks for introducing me. I'm honored to be here to present our project about a novel screening test for the diagnosis of endometrial cancer using metabolomics. We called our test MEDEA, which stands for Metabolomics for the early detection of endometrial adenocarcinomas, and has been patented both in Italy as well as in almost all the European countries, in South Africa, in Japan, and the USA. These are my disclosure. To begin with, please let me tell you something about the endometrial cancer. That is a neoplasm of the tissue that line the uterus internally. Most cancer of the endometrium are adenocarcinomas, that are cancer which originates in the cell that produce and release mucus as well as other liquid substances. Endometrial cancer represents the most common neoplasm of the female reproductive system. So more than 88,000 diagnoses per year in Europe was made. This number is constantly increasing, and it is the 7th most common cause of cancer-related death in Europe. However, to date, what causes endometrial cancer has not yet been identified, while it was possible to identify some risk factors. Most relevant ones are aging, genes, obesity, and of course diabetes. Moreover, other evidence indicates that hypertension, nulliparity, and having a higher number of menstrual cycles over the lifetime increase the risk for this cancer. The most common sign of endometrial cancer is vaginal bleeding. This sign, in particular after menopause, should be considered a warning. To date, unfortunately, especially in many rural settings, it's considered an embarrassment that slows down and hinders the consultation with the gynecologist. Regarding the diagnosis, transvaginal ultrasound can be used. It's useful to observe the uterus and to measure the thickness of the endometrial, but a definitive diagnosis can only be made by sampling the endometrial cancer. So a biopsy, often by means of an hysteroscopy, is needed. This is, of course, a very invasive procedure. About the prognosis, endometrial cancer prognosis depends on several factors, among which the most relevant are staging and cancer tissue. Two variants, indeed, has been described. Type 1 develops in the peri- and postmenopausal age on a substrate of endometrial hyperplasia and has a better prognosis. Type 2, on contrary, arises on average 10 years later on a substrate of endometrial atrophy and has a worse prognosis. Prognosis is also closely related to the early detection. Indeed, as you can see, 5-year survival rate decreased dramatically from 95% in the case of stage 1 to just 17% in the case of stage 4. However, there is currently no mass screening available for this cancer. Based on these premises, we decided to develop a screening system based on metabolomics, of course, to enable the early and non-invasive diagnosis of this cancer. We followed a stepwise pathway. First, we enrolled patients and with an established diagnosis of endometrial cancer, as well as a corresponding cohort of healthy women. And we trained different classification models to recognize this condition. Then we tested the specificity of this profiling system, enrolling with women with other gynecological conditions, both oncological and non-oncological. In 2020, we performed our first validation study by enrolling a large prospective cohort to verify the efficiency and to test it in a real clinical setting. Currently, we have just completed a second level of validation involving a large cohort of women undergoing two hysteroscopy, and further steps have already been planned. The case control study was conducted in 5 steps. We, of course, enrolled both cases and controls and collected serum sample by venipuncture after 20-hour fasting period and before any drug administration. Endometrial cancer, in terms of diagnosis, grade, and histotype, were confirmed by pathological examination after hysteroscopy. So we extract metabolome, purify, and derivatize it, and we use gas chromatography affinated to single quad mass spectrometry to separate metabolites and to get a semi-quantitative data set. We used 2 isopropyl malic acid as an internal standard. After data pre-treatment, dataset was used to train several classification models. No class imbalance treatment was provided due to the very limited difference between cases and control sites. All models were then combined in an ensemble machine learning approach using a voting scheme. The relevant metabolites that were investigated both in terms of class distribution and also within a pathway analysis. More in detail, we performed 2 separate recruitments. In the first one, we enrolled 88 patients with endometrial cancer in different stages and grades, as well as 18 healthy controls to train the classification model. In the second one, we enrolled an additional 30 patients with endometrial cancer, most of which were in the very early stage, patients with ovarian cancer, that is a condition sharing several signs and symptoms, as well as several biochemical perturbations with endometrial cancer. Moreover, we enrolled health patients, health subjects, of course, and women with benign endometrial disease like myomas, polyps, all conditions also causing vaginal bleeding. This second enrollment was used to evaluate, as a mini external validation step, the diagnostic performance of the trained model. As said, sample analysis was performed via ZCMS using derivatized metabolome. This step was achieved using 2 reactions, methoxylation to protect the carbonyl groups and a cyanidization to decrease the metabolite's boiling point. The GC and MS condition applied, as well as a typical chromatogram before and after spectral deconvolution are shown in this figure. Samples were divided in batch, and each batch was monitored with 4 controls: a blank injection, an injection of a standard mix, an injection of a pooled sample, and a replicate injection of 1 sample for each batch. Moreover, we used the alkyl mix solution to evaluate the metabolites Kovacs index. Semi-quantitative results were included in a dataset, which was pre-treated in order to align chromatographic data, normalize, and we normalized with the internal standard area, auto-scale and log transform all the data to normalize the distribution. The dataset was used to train several classification models, but first of all, we trained a PLSDA model. The results are shown in this figure. As you can see, the model results in a statistical significant permutation test with a non-negative Q-square showing no overfitting. As you can be seen, the endometrial cancer patients, that are the green one, appears to be grouped in two distinct clusters. When analyzing the similarity between these patients, we saw that all the women in the upper cluster had type 1 endometrial cancer, while those in the lower cluster had type 2 cancer. So, based on these premises, we trained a separate model to classify patients with endometrial cancer according to the tumor histotype. As you can see, also this model showed good performance as well as no overfitting. Moreover, other 7 classification models were trained using the same dataset, namely decision tree, naive Bayesian, random forest, KNN, artificial neural network, linear discriminant analysis, and support vector machine. For each model, the cross-validation accuracy was also evaluated. A weighted voting scheme was used to ensemble all these models. Specifically, each trained model was queried using the second mean validation enrollment. Each sample was classified as a control or as endometrial cancer by each model, and for each classification, both the cross-validation accuracy as well as the classification confidence were evaluated and multiplied. So we get a score for each sample and for each classification. This considers both the model credibility using the accuracy as an estimator as well as the single classification strength using, for example, the distance from the class centroid as a classification confidence. For each classification as endometrial cancer, this score was considered as is, while for each classification as controls, this score was further multiplied for -1. As a result, we get a total score summing all the singular score. This score will be 0 in the case of an unequal classification as endometrial cancer or controls with the same strength, while a score higher than 0 indicated the presence of endometrial cancer, and a score below 0 indicates probably an healthy control. As can be seen, this is a very efficient system. Indeed, although no classification model achieve 100% accuracy, the ensemble machine learning did. Okay. Metabolomics also allow us to evaluate the metabolites with the higher relevance in terms of class separation. We used several criteria to do this, like the area under the rock curve, the volcanoplot selection, the WIP selection, and so on. These metabolites were also evaluated altogether in a context of a pathway analysis. Globally, low glucose and high lactic acid concentration were observed in serum, and this is in line with the well-described, well-known Warburg effect, common in several cancer cells. It is an increase of the glycolysis with a pyruvate reduction to lactic acid. Recent evidence, moreover, indicates that bypassing the TCA is an efficient strategy for cancer cell, which effectively mitigate the loss and reduce the apoptosis, inhibiting the mitochondria metabolism. Furthermore, elevated extracellular lactic acid is considered a neoangiogenic signal and opposes the lymphocyte activation, also reducing the immune response against the tumor. Moreover, our signature also show an involvement of progesterone and a significant dependence on glutamine due to the need to produce acetyl coenzyme A to build fatty acid, probably. So, we moved to explore the performance of the test in a real clinical setting. In cooperation with the LILT, that is the Italian League for the Fight Against the Tumor, we organized a clinical trial in which postmenopausal women visiting the gynecological clinics were enrolled. We collected blood samples from all these women and carry out a comprehensive anamnestic and gynecological examination. We also performed a separate enrollment of women with endometrial cancer and healthy control to retrain all the model. This was necessary for two reasons. First, we decided to move to not use the traditional blood sample by venipuncture, but a less invasive dry blood spot sampling. This allows us to increase the non-invasivity of the test and also to reduce the costs for storage and for shipping the frozen samples. Of course, the metabolomic profile get by DBS samples are not perfectly superimposable to those obtained on serum, so new training on DBS samples profiling was necessary. In addition, the changes related to GCMS condition after several months, like column change, detector deterioration, and so on and so forth, make it very difficult to use pre-trained model. All acquired chromatogram, of course, were aligned, and we used the parametric time wrapping algorithm to do it. But we were also only able to correct for a small variation in retention time between the sample, whereas a long time interval between training and interrogation require a large shift that generates many errors. This is one of the big limitations of our total untargeted approach that we're still facing. Anyway, we enrolled 50 endometrial cancer affected patients, as well as 17 controls, to retrain all the classification model, and 1,430 women with an unknown status of endometrial cancer. With this sample, we test all the model. All the enrolled women were also revisited after 1 year to check for the presence or the absence of a diagnosis of endometrial cancer. Subject found to be as probable endometrial cancer by the machine learning approach was further confirmed by hysteroscopy. Okay, these are the results of the PLSDA model. We obtained training the profile get by the DBS samples. As you can see, also this kind of approach, this kind of sampling is a valid and robust model to make this kind of diagnosis. Furthermore, all the other models show good performance, and the ensemble in cross-validation also still show 100% accuracy. In the validation cohort, we detect 18 cases as endometrial cancer, using 0 as a cutoff value. Of these, 2 seems to be false positive, as hysteroscopy did not reveal the presence of the tumor. However, we know that hysteroscopy showed low sensitivity in asymptomatic women, so these are still under observation to further confirm them as a real false positive. Under other 16 confirmed cases, most were at a very early stage that allows surgical-only treatment with a very good prognosis. We also evaluated a new potential cutoff that is based on Uden index. In the next future, we will test both cutoff. In general, from a screening perspective, false positive are to be preferred, while false negative are to be minimized. As the false negative will not receive further attention, while the false positive error can be easily corrected by follow-up or by other confirmatory tests. Based on these premises, we think that 0 seems to be better and more protective threshold. This report were already published in 2 separate papers. Although, of course, these are relevant, the low amount of discovered endometrial cancer cases in the validation cohort does not convincingly support the diagnosis performance of such an approach. So we decided to change experimental design, trying to identify endometrial cancer cases in a cohort of symptomatic women undergoing hysteroscopy. So we globally enrolled 871 women, of which some had no endometrial or uterine disease, like controls. Other had non-oncological gynecological disease like polyps, myomas, cysts, endometriosis, and so on. Other had cancer but not related to endometrial, like ovarian cancer, breast cancer, vaginal cancer, and so on. And 126 resulted with endometrial cancer. We train the classification model again with all the sample collected until now. And we use the metabolomic profile obtained by this woman to blind test the model. As you can see, the PLSDI model retrained was result in good performance, and the role of the warming effect as well as the glutamine addiction was already confirmed. This figure showed the score of all the analyzed patients for all the classes. As you can see, the ensemble machine learning based screening show low error rate, less than 5%, in identifying endometrial cancer among all the women. Patients affected by other cancer were also identified at very low error rates, while higher classification error were reported only for L-seal and H-seal, but this error maybe could be due to the lower sample size of these cases. For this specific setting, the Uden index-based threshold seems to be better and to show higher performance compared to the zero cutoff. Okay, concluding, although, as seen, the metabolomic profiling way for the screening of endometrial cancer resulted in a promising strategy which could contribute to change the natural history of this condition, further steps are still required. First, we need to train and testing on similar GCMS conditions, and this, of course, should be overcome. We planned to do it by moving our method from a total untargeted approach to a broad targeted analysis in which we will select a subset of metabolites and accurately quantify them. This, we hope, will allow to feed the classification model with a reproducible dataset that can be obtained under very different conditions. In addition, we will further investigate several conditions that may play a role in influencing the diagnostics performance. These conditions are related to both analytical and target population aspect. From the analytical point of view, we have to further investigate the DBS stability as well as the method robustness. While with regard to the target population, we have to verify if some influence, for example, in terms of different genetics, different eating habits, or can be affect the performance. Moreover, we have to check if the age in terms of the pre- and post-menopausal could have a role. In addition, the influence of comorbidity should also be verified. Finally, we are currently also exploring a new scenario in which metabolomic profile with the ensemble machine learning approach we talk about could be used as a multi-cancer screening. We trained several classification models and hierarchized them in a decision tree-like algorithm. The first model discriminates between cancer patients and healthy controls regardless of the region or the origin of the tumor. For the cancer patients, a second model is queried to check if the tumor is located in a specific organ or not, for example, the colon. The query is then iterized until all possibilities are explored. In this scenario, the test we are talking about can be considered as just a branch of such a comprehensive approach. My colleague Martina Lombardi is actively working on this project, and she will present a preliminary result in the poster section this evening. For more information, please see the poster number 573. That's all. Thank you very much for your attention, and I'm sorry for my English.
Thank you, Jacopo, for a very interesting presentation. And please, now the floor is open for questions.
Thank you for this valuable research. I'd like to ask you about the causative agent for this endometrial cancer. It would be interesting also to compare this endometrial cancer caused by human papillomavirus in perspective of metabolomics. Would you consider to study this as well, or probably it will be in the future studies? Thanks.
Thank you very much. This is a very important topic. Papillomavirus cause cancer of the neck of the uterus. That is a totally different cancer compared to endometrial. Risk factors are totally different, as well as the age of the disease and so on and so forth. But, of course, we expect that patients with cancer related to papilloma could be classified as endometrial cancer by our approach. So we try to test other oncological conditions like, for example, the tumor of the neck of the uterus, but also breast cancer or ovarian cancer, to check if the ensemble machine learning say us, yes, this is endometrial cancer, but it's not the truth. Fortunately, as I showed in one of these, okay, I don't know if we can, perfect. Other gynecological condition, in particular, this is, I don't know, this no. Okay, I'm not able to indicate, but CC is the cancer of the neck. So in this case, we have 21% of classification error. So this means that this cancer has a very, very similar biochemical perturbation. So yeah.
Thank you.
Thank you.
Okay, thank you. Thank you very much for this presentation. I have a question about the pharmacological effects. I presume the patients were on some treatment, warfarin, painkillers, and so on, not cancer-related treatment. How have you deconvoluted this impact?
Yeah, thank you very much. This is also a very, very important aspect. In some of our tests, we test for the bias, for pharmacological bias, of course, but also for age and for other anamnestic parameters. And fortunately, no influence about other kind of pharmacological treatment seems to be related to affect the performance of the test. Anyway, other comorbidities, as well as a wide analysis of pharmacological aspect, are in course. Thank you.
Hi, thank you for the talk. So I'm a computer scientist, and I have to confess that I have never seen a classifier with 100% accuracy. And so I was quite perturbed when you showed these results, because it's really not common. But then I realized that when you showed the distribution of your samples, they really looked like two completely separate groups. And so I was wondering, like, several things. Like, first, did you remove some outliers because they look linearly separable? And I think that for this you don't even need an ensemble classifier, because with a model so simple, like with a classifier with a K and N, like K nearest neighbors, you can have a very good accuracy, because if you really have two separate groups, I don't think that an ensemble was necessary. So
yeah. This is also a very, very good question. First of all, no classification model we trained show 100% accuracy. No one. We make a very hard work to future selection, and this is the reason why we chose to start our study with the gas chromatography related to mass spectrometry, and not to liquid chromatography, because with gas chromatography, although the sample preparation is more complicated and more expensive, but we have a very high resolution in terms of metabolite selection. So we can make a huge future selection that allow us to focalize the attention about the metabolites related to the condition we are studying. Anyway, no classification model show 100% accuracy. This is the reason why we decided to ensemble in such a way that is an atypical ensembling. But we think that it could be used in a diagnostic performance because the error of one classification model has been mitigated by the other because are voting. So if the majority of the models say this is an endometrial cancer, but just two make an error, this error was minimized.
Yeah, I think you have to be aware of overfitting because it really 100%. I know it sounds like fascinating, but normally the data is not that clean. And I was wondering, just one last question. In the plot that you showed when you have the distribution of your samples, what were your axes? What does the x-axis mean and the y-axis?
The figure I show was the score plot of the PLSDA model. So these are the Latin variable.
Okay, thank you.
I think that the better way to check for overfitting is, of course, an external validation. That is what we are trying to do. So, of course, in the validation, we did not achieve the 100% accuracy. For example, in the last validation I show, we just have a 95% accuracy. That is different from 100%. But the basis of the training seems solid. This is the message beyond the 100% accuracy in cross-validation, I think.
Okay, so just a last comment.
So just a short question from the next audience.
Yeah, okay, I can.
You can discuss later.
Yes, yes, thank you.
Congratulations on a very nice work. I was wondering if you can mention a little bit more about the metabolic signature of these patients. And you mentioned that glucose and glutamine was it elevated or decreased?
In serum, glucose was decreased while lactic acid was increased. This seems related to the Warburg effect. On contrary, glutamine was higher decrease, so it seems that glutamine addiction is also a feature of this signature. But this is not only related to Warburg and glutamine addiction. There are, of course, other metabolites, for example, progesterone, that we think contribute to increase the specificity of the signature.
So let's thank Jacopo once again.
And we would like to introduce our next speaker, Guro Kisegoda.